and a little bit of outcome data to think about why BPD might in fact cause not only injury to the lung, that's what it is, but brain injury. Perfect. Thank you. Okay. So this should be BPD : opportunities to injure the lungs and the brain. All right, I showed you where I'm from in my first talk. Where is it? Is it F, C, B, E, A, D? It's actually D. Cincinnati's there. Some of you are paying attention. Okay, BPD, an opportunity to injure the lungs and the brain. Does BPD predict increased brain injury? I'll try to answer that question a little bit with some clinical data. Is there a cause and effect relationship between BPD and brain injury? That's a little more difficult to answer. So what is BPD? Well, one of the problems I think we all have in clinical medicine is trying to define what this is. We have a clinical definition. It's oxygen or ventilatory support at 36 weeks, and it's a physiologic or functional definition. We have anatomic findings, and those are from a small number of babies who've been described who unfortunately have died. And that's a simplified lung. It's an arrest of lung development and a decreased microvascular development. And there's a common biochemical association with BPD, and that is inflammation. But I think truly we have a major problem of not knowing what the lung looks like of the babies who survive, which are greater than 95% of all these babies. So we really don't know what these lungs look like, and thus I think we have a real gap in knowledge there. You've seen this in a variety of forms. And Dr. Morley just talked to you about this little piece here, and I'll talk a little bit about this tomorrow. But again, I think one of the problems with trying to come to grips with BPD is it has so many contributing etiologies. It probably also has a whole bunch of different anatomies and characteristics at the BPD end out here that are driving these outcomes and ultimately then associations with brain injury. Just to tell you what you all know, these are recent data from the NICHD Neonatal Network on RDS and BPD. Most of our babies, these are data from 2003 and 2007, almost 10,000 babies up to 28 weeks gestation. BPD is a function of gestational age, all else being equal. And this is the use of CPAP in this population. Now, there's BPD and there's BPD. There's the bad form of it. If we categorize BPD in this population, again in almost 10,000 babies, 68% of the population had BPD. If it was called mild BPD, that's an oxygen use for 28 days after birth. This is the profile versus gestational age. If one looks at moderate BPD, this is the profile, and this is the profile for severe BPD. So clearly the kind of BPD that gives us the most trouble is the severe BPD, and that is incredibly gestationally age dependent. Now we also know that neurodevelopmental outcome is very gestationally age dependent. And so the question is, are these curves for neurodevelopmental outcome and for BPD in any way related? A little more information on our babies with BPD, and I think this just is to give us a sense of how little we really understand about this problem. This is a group of over 1,300 babies who are less than 28 weeks gestation, where their oxygen use for the first 14 days was categorized as either persistent and increasing, initially improving and then increasing, or consistently requiring very low oxygen. These babies are essentially on room air. Now, how are these babies cared for? Well, the majority of all these babies got surfactant. The majority of these babies, the 84%, are still ventilated at 7 days. 50% of these babies are ventilated at 7 days, and 21% of these babies are still ventilated at 7 days. Now, that's a kind of care that we wouldn't have in our unit because we would have far more of these babies off the ventilator on CPAP. Nevertheless, the BPD occurrence, I think, is quite interesting. It's 67% in this population, and this is the population most people assume are going to have BPD. They're sick, they're persistently sick at 14 days, and they end up with BPD. However, 50% of these babies develop BPD, and 17% of these babies develop BPD who actually had very little oxygen requirement in the first 14 days of life. So you can look at this a lot of ways, and you can say, well, these guys got BPD because they got neck or sepsis or they had something else. It wasn't primarily a lung problem. But then why didn't all these guys get BPD? Because they had these bad lungs, 84% ventilated at 7 days of age, 50% oxygen at 14 days of age, but the BPD rate was 67%, which means 30% of these babies didn't get BPD. So again, we don't understand why some of these babies are so sick and yet escape BPD. And I think that's a bit of an enigma of these babies. We have some really good predictors of who's going to get BPD. This is a logistic regression model of the same population of babies. There's 1,200 babies in this analysis. And these babies, again, are less than 28 weeks gestation. There's some delivery indicators of the likelihood to get BPD. Preeclampsia and a fetal indication for delivery are predicting BPD very modestly, but they do predict them. Gestational age versus 27 weeks is a major predictor of BPD if you're in the 23 to 24 week category, and still certainly if you're 25 to 26 weeks. An interesting one that's become more apparent in these more recent data sets is that growth restriction, this is z-score between -1 and -2 z-scores in birth weight, in other words growth restriction, is a major predictor of BPD, and if you're even smaller, it's even a more potent predictor. So growth restriction is a really potent predictor of BPD, and this is another data set plotted a different way, looking at 23 to 31 week gestation infants, over 4,000 here now, looking at an adjusted odds ratio for BPD versus centile of birth weight corrected for gestational age. And again, if you were less than the 10th percentile corrected for your gestational age, you are really likely to get bronchopulmonary dysplasia. And now I don't understand exactly why babies who are growth restricted develop BPD. These babies also have problems with neurodevelopment. But there's two sort of obvious possibilities, and one is that the 600 gram 27 weeker is a lot harder to take care of than the 900 gram 27 weeker. So there's a bunch of technical issues that get in the way. The other thing is these babies are truly different in terms of their risk of infection and things like that, and also because their lung development is different. And there's good animal models, a lot from Australia, showing that if you're a growth-restricted fetus, a sheep or a rabbit, you actually have less lung maturation. So that may be driving this predictability with growth restriction. So can we predict risk of BPD with the data available at birth? Well, yeah, actually we can pretty well. From birth weight and gestational age, males are more at risk than females. Antenatal steroids don't help us very much any longer because virtually all of our population of babies have been exposed to antenatal steroids, so it's not a very good predictor of anything. IUGR status is a good predictor. And there's highly significant correlations, but they don't separate individuals from populations very well. So one of the holy grails that NIH wants us to study and that people have talked about today are biomarkers. Could we get a biomarker of a baby in the cord blood or in the first day or two of life that would tell us that baby's at risk for oxygen toxicity or BPD or something like that, that we could then use either to help with studies or to actually do predictive stuff for telling parents what's going on. This is a review, a recent review on biomarkers for bronchopulmonary dysplasia, and I don't expect you to read these from the back, but there's a whole bunch of things here. There are pro-inflammatory mediators, there are adhesion molecules, there are a whole variety of different things that one can measure, and these are in tracheal aspirates of these babies early in their clinical course, and basically they all predict BPD. They either are increased or they're decreased. But it turns out that they're not useful. These are data in terms of sequential data on a population of about 700 babies, looking at blood levels of all these different things which you also can't read. These are all different cytokines, chemokines, and growth factors, looking at curves for babies with and without BPD. With BPD are the dark lines, without BPD are the open lines, across the first 3 weeks of age. So we know that pro-inflammatory mediators associate with BPD, but the problem is pro-inflammatory mediators are also up in babies who don't get BPD. And when you look at these data, although these curves separate, they're quite useless as biomarkers for predicting in a population of babies. These are other data from Mikko Hallman's group in Finland doing the same sort of analysis, now factoring their babies for chorioamnionitis and no chorioamnionitis on different days after delivery, looking at plasma cytokines, and these are just some examples of which they showed for IL-6 and IL-8. And there's a lot of stars here showing significance. But again, these groups overlap so much that for making a prediction for an individual baby, it's not very useful. For studying populations, it's useful, but not for predicting for individual babies. Well, do neurodevelopmental outcomes relate to the occurrence of BPD? There's actually a fair bit of data in the literature that would support the fact that having BPD is not good for your brain. These are data in 8-year-old kids. These are somewhat old, 2003, looking at special education and IQs less than 70 for a population, not a very large population, of preterms with BPD and preterms without BPD. And they controlled here for multiple variables, duration of oxygen use, postnatal steroids, and those sorts of things. And basically, the babies that had BPD did worse than the babies without BPD. These are data from the NICHD neonatal network on a much larger number of babies, looking at severity of BPD. And dose response, of course, is always important for when you're trying to look at cause and effect. So this is dose response for BPD, controls babies that didn't have BPD. Mild BPD, again, is oxygen use for 28 days. Moderate is 36 weeks oxygen use, and severe is some sort of support at 36 weeks. And these are all little babies, and of course the problem is as they get more severe, they get smaller in general, and they get more preterm. Well, in terms of their lungs, they certainly were worse. They required more medications, and they required more rehospitalizations for their lungs. But their MDI also tracked with the severity of bronchopulmonary dysplasia. Again, that's a sort of a dose-response effect. It's not a cause and effect sort of thing, but it would certainly suggest if we could do something about BPD, we might help out the brain at the same time as an added benefit. These are Linda Van Marter's reports on over 1,000 babies at less than 28 weeks gestation who are alive at 2 years of age. This is a fairly recent data set. It was just published, looking at infants with CP and who could not walk at 2 years of age relative to severity of BPD. And the numbers here are pretty large, except in this category here. The percent with BPD clearly is related to the occurrence of oxygen use or mechanical ventilation, as is the percent unable to walk. Again, more large population-based sort of data to suggest that BPD is bad for your head. These are the same data with a multivariate analysis of the risk for CP and with some other variables thrown in, and being very preterm increased your risk. Using methylxanthines decreased your risk, not significantly, but at least in the right direction. And O2 on a ventilator, again at 36 weeks, increased your risk with that multivariate analysis. Now, this is looking at MDI and PDI in the same population of babies, looking at 915 of them that were ambulatory at less than 28, and born at less than 28 weeks gestation, and again alive at 2 years of age. This is MDI less than 55, which is not a great outcome. PDI less than 55, so this is really below 2 standard deviations. So these are significantly damaged infants. And it turns out that in this analysis, MDI was really not predicted by oxygen use or mechanical ventilation. PDI, less than 55, was almost significant with an odds ratio of 1.9. So it depends sort of how you look at these data, how you analyze it, but I think the overall sense one has of these sorts of population studies, and this one is more negative than positive, is that most of them are positive and BPD is probably bad for neurodevelopment. Now let's talk about postnatal steroids. And this has been a very interesting area that has waxed and waned in terms of people's concern about this. But this is the most recent Cochrane review by Holliday, Ehrenkrantz, and Doyle, looking at early postnatal steroids. This is the use at less than 8 days of age, and as you all know, these are old studies because few of us are using steroids soon after birth any longer. But there was certainly an increased risk ratio for cerebral palsy in this population of babies who got early postnatal steroids to prevent BPD. On the other hand, using steroids after 7 days of age to prevent BPD in babies or to get babies off ventilators and that sort of thing basically shows a favorable risk ratio for the lung outcomes and death or BPD that are actually reasonably compelling. And I think that those data would suggest to all of us that if we really have a baby at very high risk of BPD, that maybe postnatal steroids are a reasonable option for treatment. There's one concern that remains, and this is in the analysis with just 4 studies here and 200 babies, that there appears to be an increased risk of an abnormal neurologic exam following late use of postnatal steroids. I'm interested in the experience from Holland and other parts of Europe that are using predominantly hydrocortisone instead of dexamethasone for postnatal use for treatment of bronchopulmonary dysplasia. Unfortunately, these data are not randomized data in the sense that these babies are randomized to hydrocortisone or nor steroids, but I think they do give us some information that using postnatal steroids in the sense and using hydrocortisone to try to decrease BPD has some merit. And again, a hydrocortisone-treated group, not very large. No steroid group, not very large. Interestingly, the steroid group is smaller than the no steroid group, but the MR studies and IQ studies and word recall studies tend to say that these babies are equivalent, even though these babies got hydrocortisone and were in fact smaller. So there's no indication there that the use of postnatal hydrocortisone selectively in babies is a bad idea. These are other studies from Holland looking at hydrocortisone versus no hydrocortisone in relatively large babies by today's standards. And again, looking at functional brain structural and functional brain development. These should be shifted down just a bit here to line them up. But again, there's no indication at all here that the use of hydrocortisone in some babies to get them off ventilators and to get their lungs improved has had an adverse effect on neurodevelopmental outcome. These are data from the US where they did a calculation of dose of mostly betamethasone in this case, dexamethasone in this case. And what they found is when they just categorized their steroid use by tertile, that those receiving the higher doses of steroids cumulatively had a higher risk of adverse neurodevelopmental outcome. And I think these are the kinds of data, again, not randomized data, that suggest to me that if you're going to use postnatal steroids, you should be using them in short courses and lower doses. And the reason I think that we even are talking about the use of steroids are these sorts of data put together by Lex Doyle, which I think are really a compelling way to put together the data. Each of these circles is a different randomized controlled trial, and the size of the circle represents the size of the trial. And this is the effect on the outcome of death or cerebral palsy. This favors corticosteroids. This favors the control group. And this is the rate of chronic lung disease in these randomized controlled trials. And basically what these data say is if you're randomizing babies and treating babies with steroids who aren't going to develop BPD, all you're going to do is get toxicity because they're up in this quadrant, so it favors the control. But if you have a baby who has a really high risk of getting bronchopulmonary dysplasia, actually you'll have a benefit by using postnatal steroids. And so the data that we have, the more recent data we have on the potential for brain injury, which is relatively modest, and these sorts of data drive me to think that if I have a baby stuck on a ventilator at 2 weeks of age who's developing BPD, and I can get the baby off the ventilator, it's probably a good idea to do that. Because if this baby stays on the ventilator for a long period of time, the epidemiologic data suggests that both you'll have a worse lung outcome and you'll have a worse brain outcome. Caffeine for apnea of prematurity. Well, Barbara Schmidt has done this trial, which many of you may have participated in a very large number of babies. And basically, much to her surprise, because it wasn't part of her primary hypothesis, the use of caffeine decreased the use of postnatal steroids, decreased drugs for PDA, and decreased bronchopulmonary dysplasia. Well, why did it do that? One possibility, of course, is caffeine is a brain drug, and caffeine is doing something, caffeine is a lung drug, and it's doing something for the lung to improve the lung. But in fact, probably what's happening here is caffeine improves apnea of prematurity, which means you get the baby off the ventilator sooner, which may mean you have less bronchopulmonary dysplasia. So it's almost a self-fulfilling prophecy. These are the same data from the second publication looking at death or neurodevelopmental disability and cerebral palsy. And again, the use of caffeine was of benefit. Now, is caffeine a brain drug? Probably not. It may be secondary to getting the baby off the ventilator sooner and decreasing the amount of bronchopulmonary dysplasia, rather than a direct effect on the brain per se. So we've talked at this conference a lot about this whole issue of neonatal resuscitation and early management and whatnot. I think where we really lack information as a neonatal community is what we're supposed to do with these babies during the chronic phase of their illness. And so I'll just give you a clinical case. We've got an 800-grammer who weighs 25 weeks, who's 25 weeks gestation. He's on 35% oxygen on a ventilator on a pressure of 20, and he's 14 days old. So what's the risk of BPD? Well, his risk is certainly considerable based on the data from that I showed you on oxygen exposure and mechanical ventilation. It's probably about 70%. But what's the risk of BPD that's severe? In other words, high oxygen requirement and ventilation at 36 weeks. And what do we care about? Well, we really don't care if he's on 23% oxygen on a nasal cannula at 36 weeks. We really care if this kid is on significant support. And the problem with the late course of bronchopulmonary dysplasia is we have almost no clinical trials to guide our treatment decisions. And the treatment plan depends on the beliefs of the physicians or the physicians in the unit, and the beliefs of the nurses, and the beliefs of the parents, and what people want done with any particular baby, and not usually on an evidence-based basis. And I think what's really important with thinking about how we're going to treat these babies in the chronic phase of their disease, and I must emphasize, when we have the baby who's a month old, who's on a ventilator, we don't really know if he's going to get BPD. All we know is he's likely to get BPD because we can't make the diagnosis until he's 36 weeks gestation. So as a sense of the timing and disease progression, and there's 9 weeks between the time this kid is already 2 weeks old and the time he's going to be 36 weeks. That's over 2 months that we have to manage this baby to figure out what's going on. And there are two extreme kinds of decision-making, I think, that go on with these babies. One is the clinician who believes in commonly used drug therapies, and the other is the clinician who believes that most of these therapies haven't been tested and may not be effective, and that's the therapeutic nihilist. So this turns out to be, I think, how we interpret these babies relates to how we think about what their clinical course is. And what I would put to you is the following sort of situation, that what we have is a daily variance around a mean for any of us, for any of our physiologic variables. And certainly for these babies with, that are at risk of bronchopulmonary dysplasia, on some days their oxygen requirement's up a bit and the respiratory rate's up a bit. On other days it's down a bit. And some days they're breathing faster and some days they're not. And some days they're really working hard and uncomfortable. And the problem is are they really different, or are they just different that day and at that or they don't like that nurse and they like another nurse better, or mom hasn't been in, or whatever. But they have different behavior patterns at different times during the day and between days. And we all have the same thing. And so this is a daily variance around a mean of their clinical course. And this is getting better and this is getting worse. And we'd like them to have a trajectory over a period of time of continually getting better. But we know that these babies are not stable clinically. They're varying all the time because they've got a chronic illness. So the baby's now 2 months old. The baby's on CPAP and oxygen, whatever. And the clinician who comes on service for a period of 2 weeks believes that Lasix, albuterol, and aerosolized steroids will actually help a baby with BPD, or at least his nursing staff does, or somebody does. So this baby, you come on service and you try to get to know the baby for a day or two, and then the next day the baby's oxygen requirement has gone from 30% to 35%, and his respiratory rate has gone from 70 to 85. And so you say, well, the baby's worse. So what am I going to do for this baby? Well, maybe he has a few crackles in his lungs or something, so let's give him Lasix. And guess what? 2 days later, he's better. But maybe that's just his variation in his clinical course. Or maybe you were absolutely right and he needed Lasix. You don't know. So he's on Lasix. So he's better for a few days, and then he gets worse again. And now maybe somebody says, well, maybe I think he's wheezing a little bit. So let's put him on albuterol. And then, just as the sun comes up tomorrow, he gets better. And so now he's on albuterol. And then he gets worse again, and then you're going to start aerosolized steroids because you've run out of things you can try. Now, you could use GI drugs on him because lots of these babies end up on those drugs and other drugs, but this might be the order that some people would use. And just as the sun comes up, he gets better. And so now you go off service and the baby's on 3 drugs: Lasix, albuterol, and steroids. So I come on service and we'll go through the same sequence. But I'm actually a skeptic that any of these things work. I mean, I think spot Lasix in some of these babies can be effective, but chronic Lasix therapy may not be a good idea. So I come on service and the baby gets worse. Well, the first thing I have to figure out, is he really worse? And that's a physical examination, looking at the baby, trying to get a sense of what that baby's doing, and talking down the nurse that something has to be done. Well, let's wait and see. Let's wait a few hours. And so I do nothing. But then the baby gets better. So I made the right decision because the baby really wasn't worse. The baby got better. Now the baby's better, so I can do something. So I'll stop the steroids because I don't think the baby needs the steroids. And we can go through the same sequence of not doing anything if you think the baby's actually not sick, but just varying along his clinical course. And by the end of this 2-week period, the baby is off the drugs. And I think the problem is with these babies that sometimes they really are sick and we need to intervene, but a whole lot of the time we're using drugs that have not been validated for chronic use in these babies with BPD, and we don't know how to either start them correctly or stop them correctly. And the problem is once they get started, it's hard to stop them. And something we have to consider, because I think all these drugs have potential adverse effects on the brain. So in closing, I'm just going to go through these little slides again that I put together about antenatal factors. And antenatal factors drive bronchopulmonary dysplasia. And those factors really are driving inflammatory mediators, which are considered by many people in the neuroscience literature to be poison for the developing brain. So the pathway from chorioamnionitis and antenatal factors to brain injury is probably, in this sense, through inflammatory mediators, and steroids may be having direct effects on brain cells in terms of changing their behavior postnatally. Ventilation and gas exchange, we've gone over this, but again, I just think it's really important to emphasize that the advantage of a spontaneously breathing baby who's doing well is we don't have to worry about a low PCO2 or a high PCO2. And we can modulate oxygenation with our SAT monitors. So ventilation will certainly have an impact on the brain, and CPAP and spontaneous ventilation beats mechanical ventilation. Postnatal steroids, we will probably never have a definitive answer on steroids and brains because people don't want to do those randomized control studies anymore. But I do think lower dose, shorter duration therapy seems to work. It seems to benefit the lungs if you use it very selectively and the baby who's on a mechanical ventilator and you're trying to get the baby off a ventilator at perhaps 2 weeks of age. And the injury to the brain seems to be fairly modest or non-existent with that sort of use. Poor nutrition is something at this conference we haven't talked about at all, but it's probably a really important variable, both for the lung and the brain. I showed you some data that you can make the lung sensitive to oxygen simply by starving a newborn or causing growth restriction in newborn rodents. This is a new report that's not out yet that I just wanted to show you from Richard Martin, looking at cytokine expression in the brain, in an area of the brain, in 10-day-old rats following intratracheal LPS. Now, it turns out that, of course, the brain is connected with the lung, and in this case, the lung is signaling the brain to increase cytokine expression in time after exposure. And this isn't via the systemic circulation. They can blunt this by doing vagotomies and that sort of thing. So the lung, the inflamed lung is signaling the brain, and the brain is making cytokines in situ. Again, inflammation in the lung is probably not good for the brain. And then there's the things we're doing, or maybe trying to avoid, IVH, the use of caffeine, and those sorts of things. So we have to continue to evolve our care, but this is perhaps not the way to evolve. And I'll leave you with that. Thank you very much. For those of you who are not from Italy, that's not the Pope. That's Berlusconi. Okay, Dr. Morley. Let's go to the table.
Wait for the microphone, that would be good. Thank you.
Considering all the effects of the drugs for chronic lung changes, what about ibuprofen and indomethacin?
Well, the data on indomethacin are interesting. Indomethacin is an anti-inflammatory, as we all know, and ibuprofen is an anti-inflammatory. That's why you buy them at the pharmacy and use them. But the data that are available would suggest, if anything, they increase bronchopulmonary dysplasia. Now, it isn't clear why that is true, but they certainly don't decrease bronchopulmonary dysplasia when used as the indication being PDA. Now, no one has really done a trial of using indomethacin or ibuprofen as anti-inflammatories, you know, directly. I'm not sure that's a trial I'd want to do, but those are drugs that are potent drugs that are knocking out immune modulators and inflammatory modulators that may well have adverse effects on the brain. I don't know. I don't think we have the answer to that. That's not to say if you need to use the drug to manage PDA that you shouldn't be using the drug. But I just think we haven't thought about the drugs we use for BPD chronically on the brain. So is Lasix a problem? Well, Lasix completely screws up your electrolytes, and your bicarbonate goes up, and you know, and your potassium goes down. And are those things bad for the brain? I don't know.
The closure of the ductus, would that decrease incidence of the PDA?
Of BPD.
BPD, sorry.
Well, there's a lot of people who believe fervently that a PDA needs to be closed. And there's a whole bunch of people now who are starting to think that we should ignore the PDA. And like all extremes of religion and science and everything else, they're probably both wrong. There's someplace in the middle that there's some PDAs that are a problem, and there's a lot of them that aren't a problem, and we don't know which are which. That's the problem. It's clear, and the problem, the other piece of the problem, of course, is that if you're going to use indomethacin or ibuprofen, you have to use it early in the clinical course or it doesn't work. Each of us have somewhat different ways of managing PDA, and PDA is probably a contributor to some cases of bronchopulmonary dysplasia because you do get increased perfusion of the lung with blood. And there are monkey data that are quite interesting that is associated with an arrest of lung development. But the PDA is probably less of an issue than people used to think it was. Dr. Morley, your thoughts?
Oh, yes. I mean, I think this is like so many things. We've got ourselves into history. You know, hey, you can listen. Here, duct. Whoa, frighten it away, give some indomethacin. And that's what I was taught as a young guy. And then, of course, all you clever guys with your ultrasound. This is a significant duct. The report comes back. Oh, really? The baby doesn't look too bad to me. So, you know, we've got in the history of being able to listen and to report this thing. There are many people who I'm sure you've heard speak who are absolutely ardent that ducts cause BPD. Ligate them, get rid of them. One course of indomethacin, and if it doesn't work, ligate the duct. And you go to their units, and there's 20% of these little babies having their ducts ligated to reduce BPD. And I was at a meeting with one of these guys who won't be, I won't name, who's you know, passionate about closing the duct. The incidence in his BPD in his unit, gestation by gestation, was identical to ours in Melbourne, where we probably don't ligate more than about 5 ducts a year, and we have 120 babies under 1,000 grams. So I'm not at all convinced that it is a real contributor to BPD. These are premature babies. This is an association, okay? They get ducts, they get BPD, they get other things. To say that one causes the other. Now we've got the data too from Lex Doyle and others that if you ligate the duct, or let's say if you operate on the baby, they have adverse neurodevelopmental outcomes. Surgery for babies, whether it's duct or other things, is bad. And, you know, who wants their chest open, for goodness sake? And, you know, Alan's very keen on inflammation and cytokines. My golly, if you want to stir up a few inflammations and cytokines, operate on somebody. And so, you know, I just think it's increasingly, units are not treating ducts and seem to be getting just as good outcome without it. Now, how do you pick the winners and the losers? Which ones are you going to treat? And if you're going to treat them, treat early. I think is very difficult, and we need people better than I am. Except my personal philosophy is, don't operate on a baby unless you've absolutely got to. And I'm afraid I was famous in Melbourne. They'd say, oh, here's a baby still on a ventilator. We're going to operate on it. This was a Friday night. We're operating its duct on Monday. I'd have it on CPAP on Sunday. So on Monday they wouldn't operate on it because it was on CPAP and not on the ventilator. And then everybody forgot the duct because it was on CPAP, and not a problem. So I think we need some good trials, and they're beginning to start. I know Carl Bose was talking about it. Going right back to the beginning. Should we be treating them at all, indomethacin? Should we be operating on? How do we know which ones? And it's, as far as I'm concerned, it's all up in the air again. Did I say the right things?
That was really clear, wasn't it? I think the problem is that we've all seen these babies with PDAs who seem to really have a problem with the PDA. But the problem is it's late in the clinical course. And then those babies really don't like to have their PDAs tied. They don't do well. So there's no perfect solution to this. Come on, questions.
Don't you think you've tried to link the brain damage to BPD? Don't you think you're just looking at statistical data or clinical symptoms of just babies who are prematures and very sick? You can also link into ROP, you can also link into NEC, that's also...
You're absolutely right. Sick babies do badly. It's pretty clear. I mean, I showed you, I made the statement earlier that the babies you have in your unit that have the highest saturations are the babies on room air. But they don't have BPD and they don't have ROP and they don't have NEC and everything else. So it's the sick babies who have all these things and they're all interrelated, and a multifactorial analysis doesn't solve the problem. The only thing I think we do have is we have animal model data as proof of principle and cell biology data to say that inflammation per se is not good for the developing brain. And there's actually an interesting study years ago, and I can't quote it precisely, but where one of these interferons was given to very young kids within the first year of life for a tumor treatment or something like that. And those kids developed CP. So there's a lot of data to say that the developing brain doesn't like inflammation. And there's no question that BPD is associated with inflammation. So I think that causality pathway is at least plausible. And the only way to avoid it is to avoid BPD. And again, I think it's also plausible to say that we know, at least in term babies, that low PCO2 values are really not good for you. That to say, if we put a baby on an oscillator and we look the next day and the CO2 is 25, that's probably not good for the baby's brain. And if you don't have to ventilate the baby, you don't have that problem. So I think that there's a lot of causal pathways that are consistent with the fact that BPD and bad neurodevelopmental outcome are linked. But a true cause and effect pathway will probably never be demonstrated. So I was trying to just bring the two parts of the conference together a little bit to integrate it, but I think I think you're absolutely right. These are associations, and they will stay associations. Because if we can prevent BPD, then we have better babies, and they won't have as much brain damage. Thoughts?
Alan always says the truth.
I would like to ask a question to Professor Marley. May I, or we have to wait?
No, anybody.
Okay. And when you suggest us to use CPAP level 8 to 10 centimeters of water, it sounds to me terrible, because even 8, it's high to me. Aren't you worried about cardiac output or something like that for small infants?
If Professor Kessler was here, he would say you're a peepophobic. Okay. You go to the pediatric intensive care and they will be using PEEP levels easily in that range and higher. And so what do you use, 5?
5 to 6.
Why? What evidence is there for 5 or 6? This is another bit of it's got into history. And we know that that works. But one of the things I think it's important that PEEP, just like everything else, is something, a CPAP, is something we need to think about looking at the baby and adjusting depending on what's happening. So the baby's oxygen's rising, the baby's recessing, its X-ray shows almost a whiteout. That baby's saying, hey doc, I need a bit more help to get my lungs open. I'm struggling myself. Please give me a bit more pressure or even ventilate me. Now, it's interesting if you go back to George Gregory's original paper, not our little premies, bigger babies, but he was using 12, 15 millimeters of mercury. Am I right there?
Well, he was using 12.
12.
Bob DeLemos used 20.
20. So, and all I can say is in our lamb studies, we got better oxygenation and better FRC with higher things. So we could even go and argue the other way, that having a pressure, end pressure that's too low, you're predisposing the babies to more atelectasis and more shearing forces than opening them. Now, you mentioned pulmonary blood flow, interfering with pulmonary blood flow. You will only interfere with pulmonary blood flow if you put PEEP and high PEEP on normal lungs. Okay. And you can, clinically, if the baby's needing oxygen, particularly more than a small amount, it's got lung disease, you can see it's working hard, you can see the X-ray, you've got to put the PEEP up very high, the CPAP, PEEP up very high to interfere with pulmonary blood flow significantly. Now, in some of our lamb studies, as we put the PEEP up, the pulmonary blood flow did go down. But hey, the oxygenation got better, and there's a great redundancy in pulmonary blood flow. You know, it's a very important thing. So you can afford to reduce it a bit, and you're still getting good effects. So it's just you just you know, just have a look at the baby, and there are some babies who need more, and neonatologists have got very hooked on 5. Oh, we'll be brave and use 6. What about 8 or 10?
I'll try.
The other way to think about this is, again, the time and what you're trying to treat.
What you're trying to treat.
So if you're in a delivery room and you've got a fluid-filled lung, a pressure of 8 or 10 transiently is probably not excessive at all, because you're not going to transmit that to the interthoracic space, and you're going to try to get that fluid out of the lung. So in the delivery room, you're trying to move fluid out of the lung. If you have the baby who's now a half hour old, 45 minutes old, and who has RDS, then your problem is recruiting lung volume. And if you were a believer, how many people here use high-frequency oscillators predominantly in their babies? So there's a fair number of people. And that, you know, that's a style issue. Some of us use conventional ventilators, some use high-frequency oscillators. But Anton van Kam in Amsterdam uses oscillators. And he's done a really interesting study that was published a few years ago, where he took 100 babies with RDS who were intubated, just intubated at birth, and tried to, and demonstrated that if you give them enough pressure, they will oxygenate. And his definition of oxygenate was that these babies with RDS would require 25% or less oxygen if you got their lung open. Because as you know, if you're trying to oscillate a baby, you want the lung open. Well, how much pressure did it take to get the lung open? This is mean airway pressure now. So this is mean airway pressure on an oscillator is the same as PEEP, which is the same as CPAP, 21 centimeters of water. So he increased those babies' lungs up to 21 centimeters of water as a mean value. Some of them were higher, some of them were lower, and they required less than 25% oxygen. And then he could bring them down to about 14 mean airway pressure to oscillate them chronically. Now, I wouldn't do it that way. I'd give them surfactant and then open their lung. But that's, again, a different issue. But the point is that it takes a lot of pressure to get the lung open relatively rapidly. Dr. Morley showed you an X-ray of preterm bunnies who he's trying to get water out of the lung with a long initial inspiratory pause of 20 seconds. Well, that was 35 centimeters of water. So if you're truly trying to open the lung, a CPAP or PEEP of 5 is not going to do it. That doesn't mean it's not the way to do it. It may be less or more harmful than doing it some other way, but if you really want to get the lung open, you're going to have to use a lot more pressure. And in some of these babies without surfactant, you need more pressure. So I think it depends on when you're treating the baby. So I would argue, and this is just my opinion, that if you're in the delivery room and you have a baby who seems to have a very stiff lung, that maybe more PEEP was a good idea because you can get that lung open. If you're treating a baby in the nursery who's got significant respiratory failure and surfactant deficiency, that maybe a little extra PEEP is going to be good because it's going to push that surfactant down more, get that lung open, and then maybe you want to back off. So I'm not and I'm an early surfactant treater in this CPAP series of things. So if a baby's on 30% oxygen, I get an X-ray. If he's got RDS, I'm thinking about treating with surfactant, even though it's only 30% oxygen if the kid's on CPAP. That means treat and extubate. But if he's going up to 40% oxygen, he needs surfactant treatment. That's just my decision tree. And once you give him surfactant, a PEEP of 5 is probably just fine. But, so I'm not a high PEEP user. When you've got the kid on surfactant, you've got him treated, and again, unless he's got a whiteout, and then you go to an oscillator, what do? You go way up on the mean airway pressure. So you're afraid to use a CPAP of 5, but when you intubate the baby and put him on an oscillator, he's on a mean airway pressure of 12, right? And those are the same things, actually. So I think it's how you think about what you're doing and what time course of the disease, how you want to intervene. Does that make sense?
Yeah.
Wake up.
No, I'm listening to every word you say. You see, I would just, on Alan, if he's got a baby in 40% oxygen on a CPAP of 5, and he wants to intubate it, give it surfactant, put it on a ventilator, I'd say put the CPAP up and see what happens. A lot of those babies, you put the CPAP up, improve the lungs and their oxygen will go down, and he doesn't need to give it CPAP. So I think this business of, cut-off levels of oxygen that people are saying, yes, providing you've got the lungs open with reasonable levels of CPAP and you're delivering the CPAP properly. But we've seen a whole number of situations where you put the CPAP up, the baby's oxygen improves. And now there's people doing studies, the high frequency, we've had, recruit the lung. Now people are beginning to do studies of recruit the lung on CPAP as well. So I think we will see transiently higher levels used, but it depends on the disease you're treating or the condition. Can I ask Alan a question? Alan, I've heard, oh, you want, okay.
Go ahead and get the microphone over to her.
Okay. Alan, and you've written, and many other times I've heard you say that really the problem with BPD is it's these very tiny babies whose lungs are at a developmental stage that is so immature that they just do not have the capacity once they're ex utero to grow and develop whatever we do. They're just too small. What do you say to that?
Well, I think there's pretty good data from pulmonary function testing and follow-up testing that no baby who's born at less than 1,000 grams has normal lungs at term. So all these babies have some developmental abnormality. It's a question of how bad it is. So BPD is just part of a spectrum of some abnormality to significant abnormality. And I mean, we know that if you've been born at less than 1,000 grams, your use of pulmonary drugs and hospitalization for drug pulmonary problems and whatnot in the first year is much, much higher than a term baby. So they have lung problems. It's just a question of how bad it is. And what's amazing is that they can actually grow out of most of this, and they ultimately do quite well. We really don't know what their lungs look like. I mean, your and my lungs have so much reserve relative to gas exchange and blood flow. Some of us are not marathon runners, but for some of those of you who are, you're the only one that actually tests the potential of your lungs. And so our babies could have half the number of alveoli at 20 years of age that you and I have, and we'd never know it unless we do elegant functional testing or lung biopsies, and we can't do that. So we don't really know how these lungs are growing and developing, and they may be considerably abnormal, and we don't know how they age. And I think, the dream of the CPAP believers, and I'm one of them, has always been that, well, if we use CPAP effectively in the delivery room and in the early weeks of life, we will prevent BPD. And the data are clearly that that's not true. I mean, maybe we have less severe BPD, but babies still have bronchopulmonary dysplasia. And I mean, I just think that a lung of a 25-week baby that has to breathe and has to stretch and whatnot, those effects are enough to alter the developmental sequence that they're all abnormal to a degree. We just don't know how much.
Question over there.
In our clinic, we changed the threshold of saturations with the post-conceptional age of 37 weeks from 85% till 93%. And we see that the BPD patients, when they're 36 weeks, they don't have any respiratory support, and a week later they need oxygen. What's the best thing to do?
So when you increase your threshold, then you need more, you're using more oxygen.
Before we don't need any oxygen.
Yeah, and now you do. Well, for one thing, you're asking them to need more oxygen, but I mean, I don't know. I mean, there's the old stop-ROP trial, which was regulating oxygen levels that, you know, I mean, these are competing outcomes. From both from the NICHD trial and from stop-ROP, not so compellingly. In the NICHD trial, if you target lower saturations for the whole clinical course, you have less ROP, you know, P less than 0.00001. The bad news is you have more mortality and a bit more BPD. So, I mean, I think that these are competing outcomes, and that's the problem. There's probably no perfect, if you could regulate oxygen saturation to a value, which you can't, there's probably no perfect value for the brain, the lung, the eyes, and the other parts of the baby. And so I think we have to take a middle-of-the-road approach, and whenever we're exposing to higher oxygen, we may increase a little bit of lung injury. On the other hand, it might be good for the brain or something else. So I don't think there's a right answer. And I suspect that when all of these oxygen trials get done with these target ranges, and you know there's the support trial's done, the UK trial is done but not reported.
Stuff being presented and published in this next couple of weeks.
Yeah, so there'll be even more information coming out. But I suspect at the end of that, we're going to have to sit back and say, okay, we've got 3 or 4 trials, we've got all those babies, we've got a meta-analysis, we're going to have to decide what to use because no one's going to do a lot more of these trials. They're just too hard. And at the end of the day, when folks do the curve of how effectively they were able to keep their babies within the the targets, it isn't very good anyway. So.
Okay, can I just stretch you out on that a bit more, Alan? You've been talking about BPD, and we've got a very nice example. You change the incidence of BPD quite dramatically just by changing your oxygen targets. Can I suggest to you that this diagnosis of BPD, of being in any oxygen at 36 weeks, is a very unsatisfactory diagnosis? You can be in 22% oxygen at 36, and you get in his, whoa, wow, you got BPD, you must be bad. Okay, and I'm just frustrated by this whole diagnosis. Why oxygen at 36 weeks? Why any oxygen? Why not something else? And the COIN trial...
So what else? That's the problem.
Well,
what else?
I would like to see, if nothing else, you know, that they're above 30% or something. I mean, the COIN trial, we report BPD, but most of those babies were in less than 30% oxygen who were diagnosed as having BPD. And they really, I mean, there was 1 or 2 who were up in 60 and 70%, but most of them were trickling along the bottom. And you look at the babies and you think, well, you haven't really got serious lung disease. And probably if we turned down the saturations a bit, they would have not been diagnosed. So it's very frustrating, Alan, and everybody's targeting BPD. You've given a whole lecture about BPD, and it's based on a diagnosis which is very ephemeral.
I agree. I mean, there is certainly the dose-response data that, you know, BPD oxygen at 36 weeks gets you in the hospital more frequently than babies that don't have that. in the first year of life, and you're taking more asthma drugs, and you have more airway reactivity and all these sorts of things. But the problem with BPD is that it is a lousy diagnosis. It's basically just a physiologic observation that a baby has an oxygen need. It doesn't relate to pulmonary function per se. It doesn't relate to radiographic findings. It doesn't relate to biochemical findings. And for most diseases that most of us get, there are multiple ways that that disease is diagnosed. And this is imperfect, but no one has a better idea right now.
Anybody have a better idea how to diagnose BPD? Tell us now, we need you.
That's why we want biomarkers, but I'm not sure they're going to work.
First question, which kind of CPAP? Bubble, another kind of CPAP? Second question is, why did you
Well, I can't remember two questions at once. Just let's take you. I'm an old man. I mean, the data is very conflicting as to which is the best CPAP, and I'm simple enough to say it's a matter of applying a pressure into the pharynx. How it gets there, whether it's from a ventilator or bubble or flow driver or whatever, is of very small significance compared with the pressure getting into the pharynx. There is some small data that the oscillations might have some benefit. Jane Pillow's keen on this, but nobody else is really reporting it very much. So, I mean, it boils down to you use what works in your unit, as long as you use short binasal prongs, don't have too long a prong because the resistance to the flow is such that you will interfere with the pressure delivery. And I'm not convinced that one device is particularly any better than the other, but others might have different views.
Second question.
I basically agree.
Second question is, why did you mention the 60 PCO2 as a cutoff? What about permissive hypercapnia that is accepted?
This is like so many of these things. It gets plucked out of the air at the time you're designing a trial. I mean, we asked around what would people think was a CO2. It was greater than 60, not 60. What would people feel uncomfortable with letting their babies get to? And the answer was, look, once they get up to 65, 70, this baby is not breathing adequately and needs more support. There was some data from Yan Wong in New York who was allowing them to go up 65 and that sort of thing. But that was almost the easiest target to set. It actually, I mean, I put up 60, it's 60 and a CO2, a pH that's, 7.20 or less. I mean, there are many older babies who'd have a CO2 in that range who are well compensated, and you certainly wouldn't think that they needed ventilating. But in the acute situation, a rising CO2 that gets to 60, that baby's not controlling its CO2 adequately. Whether you have 65 or what you go on, I don't think we got any hard data.
Yeah, I basically agree. I think the thing about PCO2 is that there's some things we don't understand very well. The normal term infant actually, with normal lungs, has a low PCO2. It's about 35. That's their normal physiology. And normal preterm infants who have truly normal lungs tend to run their PCO2s below 40 if you just let them go on their own. And if you try to do permissive hypercapnia with them, they just breathe through the ventilator. If they're on a ventilator, which they shouldn't be, but sometimes they are. So a baby will try to have a relatively low PCO2 value. So if you have a baby who's got a PCO2 value above, in the acute period over the first few days of life, who has a PCO2 certainly above 60, that baby's clearly in respiratory failure. Now maybe that's okay with you because of how you're taking care of the baby. But it is a real indication of acute, the baby is in respiratory failure. Now, when the baby gets out to weeks to months and has BPD, now clearly these kids run high PCO2s. And what's interesting about some of these babies, they will run high PCO2s and retain bicarbonate and not have respiratory distress. They just reset they act like COPD patients. They reset their requirements. And I don't, understand why they do that per se, but fortunately they do that. And you can clearly extubate a baby with BPD with a CO2 of 70 if you have to get them off a ventilator. So I think it's really, again, a time-dependent issue and what the status of the baby's respiratory control is. As long as the baby's comfortable in breathing effectively at a reasonable rate, then the PCO2 is perhaps less of an issue. But in the early days of life, these babies tend to like lower PCO2 values. And if you really want to do permissive hypercapnia on a baby who's 24 hours old, who's got normal lungs, you're going to have to paralyze or sedate the baby because he's going to drive his CO2 down on his own.
What's amazing is that we're talking about CPAP in little babies. Let's take a baby at 25 or 26 weeks. Is it 3 months early? And yet they seem to be able to control their blood gases very well with spontaneous breathing with a little bit of help. I just think that's amazing. The whole of the rest of their development is immature, and how can they breathe so well and control their blood gases? It's obviously a very fundamental part of their physiology.
I have a question a little besides the point. There are quite a few babies who are very young and they are at room air. They have 100% of saturation. Do you have any statistics about these kids? What happens to the ROP in them? Although we get them checked regularly, do you have any statistics?
I don't have any statistics, but perhaps you do. But I think the issue is those babies just don't get ROP with any frequency at all. Just as one of these kinds of things that you get when you do randomized controlled trials, the support trial was very difficult to do. It was a 4-arm trial of randomization to oxygen use and to intubation surfactant versus CPAP. And after that trial had enrolled about 100 patients, the Data Safety Monitoring Committee looked at the data. And what they found was a whole bunch of babies with saturations of 100%. And they got so upset they stopped the trial. And it turned out when they went back and analyzed the data, those were all the babies that are on room air. So the babies who were on oxygen were actually being targeted and regulated into their range. But once they get on room air, we don't put them on 19% oxygen to bring their sat down. And so that trial was actually stopped because of these babies that are on room air. And I mean, I think we just sort of know from the data sets and the correlations that we have that who has ROP? Well, babies who have ROP are babies who are long-term mechanical ventilated. They're the most immature babies. They're the babies with BPD. They're all the same babies. These little babies who do extremely well avoid these problems, even though they have high saturations. Now, they're not on oxygen, so their PO2s, let me just make another point. Their saturation may be 100%, but what is their PO2? It may be 60, because the P50 for fetal hemoglobin is 19. So once your PO2 goes up, their PO2 is not 90, 100, 120, even though they're on room air. So, and I think that's something else we have to think about. So if you think about the person who shows up in the emergency room with asthma and their saturation is 85, their PTO2 is 60, what's the response of the emergency room? Well, they're in respiratory failure. They're in severe respiratory failure with their asthma. Well, what do we have when we have a baby who's laying there chronically? His saturation is 85. His PCO2 is 60, his respiratory rate is 60, and he's on room air. And we say he has normal lungs. I mean, they're not even close to normal, but they're good enough. And so our babies who have even saturations of 95 may have a PO2 of 40. but yet we say they have normal lungs if they're on room air. So I think it's a perspective of the lungs of these babies versus the lungs of really normal people and what's abnormal. Got your hand up, Bernard?
I closed one nostril.
Pardon?
I closed one nostril.
Oh, don't close one ear.
This is with regards to BPD and antenatal inflammation. You know, Christy Waterberg published a few years ago the Waterberg paradox, that the babies that had chorioamnionitis had less highly membrane disease, but increased rates of BPD. The most recent papers don't seem to confirm that trend. Any thoughts about that?
Yeah, that's a 2-hour lecture. But in summary, I think it's just that it's Christy Waterberg's babies were ventilated babies. Her population was ventilated babies. And when Linda Van Marters looked at this, if you have chorioamnionitis, you have a decreased risk of BPD. But if you have chorioamnionitis and mechanical ventilation after delivery or postnatal sepsis, you have an increased risk of BPD. So these are competing things that are affecting the lung. And the real problem is the diagnosis of chorioamnionitis.
I was just going to ask you
Because, I mean, that's simply, if it's a clinical diagnosis, it's virtually worthless. And if it's the histologic diagnosis, it doesn't tell us anything about organism, duration, severity, or anything else. And so I think the problem is that if you use animal data as proof of principle, chorioamnionitis is the most potent lung maturational signal we have. And so if you get it just right and you have a little bit of inflammation, it's probably good for you. If you get it wrong and you've got severe inflammation, then you're a stillborn, and there's everything in between. And that's the problem with the epidemiology. Done?
There's a question that's there, and then perhaps we'll wrap
I'll
up.
wrap it up. We'll find the bus.
Sorry for that
No, no.
last question.
No problem.
I'm a pediatrician and I work in follow-up, and I wonder if you have any data on inhaled steroids, because we use it quite often with children form a BPD, and also proven on baby body plethysmography that they have obstruction of peripheral. And they have problems later. They start to be dyspnoic, failure to thrive, and things like that. So we have good experience with that, but I wonder if it's...
Well, I think it's pretty unstudied, and the problem, it's very interesting. In the neonatal unit, we are all trying not to use steroids. And guess what? When the babies go home, the follow-up people give them steroids. Now, they're at a different age, but the problem here is of course, the use of steroids mimics the use of steroids in asthma because of the issue of airway disease. It's very clear that these babies have airway disease, but it isn't clear that it's asthma and that it's inflammatory. What's his name? Beraldi in Padova has some nice studies looking at expiratory NO from babies children that are ex-BPD babies, children who have asthma, and controls. And what we know is kids with asthma have inflammation and increased secretion of NO. So the controls are here, the asthmatics are way up here, and the BPDs are actually below the controls. So it may be that their airway disease is more a fixed structural developmental problem. But on the other hand, I know in talking to folks like yourself that some of these babies seem to like steroids. So I don't think we know how to use these drugs very effectively. We're part of a 5-center consortium now who has some money from the FDA and whatnot to actually track drug use throughout the hospital course and through the first year of life to get some information about what these babies are actually exposed to, because we don't have good information on that. And it's clearly very, very variable, because they're interested in proposing studies to figure out what we should be using. I'm not sure those are going to go anywhere, but using drugs in the chronic phase of BPD in the hospital and using drugs after discharge are basically areas that have been very poorly studied. And to do it empirically, and if the baby's doing better, I can't say that's the wrong thing to do at all. It's just that we don't really know.